The slides came up, I think, if you want. Did you unshare them? No.
That's up just now?
Yeah, just if you want to reshare your slides.
Mm-hmm. If you let me know when to start, because I can't see you.
Just put it in presentation. Perfect. Give me a second.
Thank you.
Hi, everyone. Welcome to another multi-heart lecture series. Today, it's a great pleasure to introduce Dr. Andrew Chapman, who will be speaking about the current challenges in the classification of myocardial injury and infarction. Dr. Chapman is a senior lecturer and consultant interventional cardiologist at the Royal Infirmary of Edinburgh. His research interests are in the diagnosis, classification, and treatment of patients with myocardial infarction and injury. He has led research into type 2 myocardial infarction over the last 10 years, with a primary focus on the role of coronary artery disease in the pathogenesis of this condition. He's a world expert on the topic, so we're very thankful that you took the time to spend with us today. Thank you very much.
Thank you very much for the kind invitation to speak to you all today. It's a great pleasure to talk to you about an interest of mine, that is type 2 myocardial infarction. And you'll see a picture of Edinburgh to the left and Auckland to the right, and that's because recently I've spent a year in New Zealand. So I hope now that through friendships and collaborations with others across the world, I can give you a fairly global overview of where we are with the current classification of myocardial infarction. Hopefully give you some insight into current research and the directions of travel, and finally leave you with some insights as to where we might be going in the future. So I'm going to start with some basic definitions. So we all now know and are familiar that cardiac troponin can be measured in the bloodstream of the vast majority of healthy individuals, and it circulates as part of regular health and life. And when the myocardium becomes injured, cardiac troponin is released in a time-dependent manner into the bloodstream. This released in initially a peak following a number of hours of injury, and then this falls away gradually, usually over 10 to 12 days. But in recent years, high sensitivity cardiac troponin assays have meant that we recognize myocardial injury a lot more often than we used to. So the diagnostic threshold for myocardial infarction now has reduced almost tenfold in the last 15 years. And as a consequence of that, we now see troponin elevation in a wide variety of different settings. So, of course, we have traditional myocardial infarction, but also we have patients who are unwell with other acute illness. And that's led to dilemmas about how we classify and how we treat these patients. So I'm going to refer to the fourth universal definition of myocardial infarction throughout my talk. That is the worldwide accepted consensus that we should all be using. And it defines a myocardial injury as a biochemical term. So an increase in cardiac troponin in the absence of symptoms or signs of myocardial ischemia would be classified as a myocardial injury. And that can be caused by lots of different problems, by things like anemia, arrhythmia, cardiac failure, kidney disease, hypotension, hypoxia. And this can be an acute myocardial injury when there is a rise on serial testing. Typically a reference of about 20% is used, a relative 20%. That's not a firm recommendation, but it's one that's often applied. Or there could be a chronic myocardial injury, and this is a setting that tends to be more common in patients with chronic kidney disease, where these stable troponin elevations are noted, or indeed in patients with hypertensive heart disease. For a myocardial injury to be classified as myocardial infarction, there has to be an acute rise and or fall in cardiac troponin concentration on serial testing, accompanied by either symptoms of myocardial ischemia, typical sounding chest pain with radiation, signs of myocardial ischemia on the electrocardiogram, be that T-wave inversion, ST depression, ST elevation, or regional wall motion abnormalities on cardiac imaging. So the diagnosis of myocardial infarction is a clinical one, symptoms or signs accompanied by that biomarker change. So a type 1 myocardial infarction is due to atherosclerotic plaque rupture and thrombosis. And a type 2 myocardial infarction is an umbrella term. It's a heterogeneous term, and it encompasses a wide variety of different disease mechanisms. So spontaneous coronary artery dissection, coronary embolism, coronary vasospasm, patients who may have fixed obstructive coronary artery disease, and those patients without coronary artery disease. So that's one of the first concepts I want to illustrate, is that you can be labeling your patient who comes in with chest discomfort, a rise and or fall in cardiac troponin concentration in the context of a supraventricular tachycardia with a rate of 240 beats per minute. They may have pristine coronary arteries, but at present, according to the classification, they may be diagnosed with type 2 myocardial infarction, which has implications for that patient not only today, but also tomorrow with regard to driving regulations, at least in the United Kingdom, and also for their insurance premium. So what do we know about acute myocardial injury? Well, we know that it's also common. It can happen for a variety of different reasons: direct toxicity, myocarditis, pulmonary embolism with strain being the most common causes. And these two conditions taken together are responsible for around 50% of all troponin elevation that we see in consecutive hospitalized patients. We look at cardiac outcomes and we look at all-cause mortality. So when classified by the index diagnosis, so type 1 myocardial infarction represented here in red, that's atherosclerotic plaque rupture. Type 2 myocardial infarction due to a supply or demand imbalance, typically tachyarrhythmia in over 50% in blue. And then myocardial injury is those patients who do not have ischemia. But if you look out to 5 years, we can see that just 1 in 3 patients with type 2 MI is still alive. There is an increased risk of further myocardial infarction. That 1 in 8 patients will have an MI within 12 months. That might be a type 1 or a type 2. There is a 6-fold increased risk of having a recurrent type 2 myocardial infarction if you've had one already. And taken together, the cardiovascular risk for an individual patient with type 2 MI is actually equivalent to type 1 MI. And we came up with this central dogma a couple of years ago now, which is an illustration showing really the risk factors for type 2 myocardial infarction, which come from the acute illness process, which may be anemia, hypotension, hypoxemia, for example. Those risk factors for impaired coronary blood flow, which may be mild, moderate, or severe plaque disease in the context of other cardiovascular risk factors. And together, there's an integrated risk of myocardial supply or demand imbalance, which could either translate to a myocardial injury without ischemia, or the other extreme, clear evidence of ischemia and type 2 myocardial infarction. So what are the challenges in type 2 MI? Well, the diagnosis is challenging. Knowing who to investigate and treat is challenging. And knowing how to risk stratify is challenging. And there is also significant contention about this definition. Although this is accepted and I would recommend that you use it in practice, there are alternatives which have been proposed by at least 3 research groups that I'm aware of. And the truth is, although the guideline tells us that type 1 and type 2 myocardial infarction are separate entities, there is likely to be a significant overlap. The only way you can truly distinguish a type 1 from a type 2 myocardial infarction is to do a coronary angiogram, pass a coronary wire, and use an optical coherence tomography catheter to give you a cross-sectional view of that coronary artery to look for evidence of atherosclerotic plaque rupture or erosion and overlying thrombus. And that is, of course, currently not sustainable or not indicated in our clinical practice. So there is a degree of subjectivity, which we will come back to. What do we know about type 2 MI? Well, the DEMAND MI study was a cohort study I led in 2021 with my colleague, Dr. Anda Bularga. And we applied the 4th universal definition criteria to consecutive hospitalized patients. And we came up with 100 patients who had a clinical diagnosis of type 2 MI. And I want to emphasize that this was a robust process with prospective adjudication, objective evidence of supply or demand imbalance on the patient's record, in conjunction with those criteria that I've informed you are essential for the diagnosis. So we felt that we'd really applied stringent criteria. And of those 100 patients, we wanted to understand what was happening in the coronary arteries and what was happening with left ventricular function. So we applied systematic cardiac imaging. Following cardiac imaging, in those 100 patients, just 93 had a diagnosis of type 2 myocardial infarction. So our expert panel prospectively adjudicating the classification were correct 9 times out of 10. 5 patients on imaging had evidence of a plaque rupture or thrombosis, and 2 patients had confirmed myocarditis or stress cardiomyopathy on echo and cardiac MRI. We recruited a slightly selected population of patients, so with an age of 66 years, these are slightly younger than you might anticipate. 44% were women, and in most consecutive patient studies, the prevalence is about 55% of women. Traditional risk factors and peak troponin I concentrations of 1,165, so moderate cardiac troponin elevation. And we had objective evidence of myocardial ischemia in 76%. We found obstructive coronary artery disease underlying type 2 MI in 1/3 of patients. Almost 40% of patients had non-obstructive coronary artery disease, and just 1 in 3 patients had normal coronary arteries. And here I've given you an example of a patient who presented following an episode of palpitation with rapid ventricular rate followed by an episode of syncope, and they were found to have 3-vessel coronary artery disease during this study. No preceding anginal symptoms. We also looked at evidence of left ventricular systolic impairment, and we found that 1 in 3 patients had evidence of LV dysfunction. And we found multiple different interesting patterns of late gadolinium enhancement on cardiac MRI, some of which are represented here. And I would draw your attention to panel D, which is coronary embolism, where a patient has at least 50% subendocardial late gadolinium enhancement, which would be consistent with an occluded artery or a STEMI pattern. And we found some other interesting patterns due to SCAD, due to vasospasm, or indeed due to hypoxemia. This is quite an interesting illustration, which really tells you where patients start to the left-hand side and where they end on the right-hand side. And really what I want to impress upon you is that the patients in dark blue have no evidence on cardiac imaging, on MRI, of having a myocardial infarction. So just 42% of those with a clinical diagnosis and an adjudicated diagnosis of type 2 MI actually had any imaging evidence of having a myocardial infarction, showing you just how sensitive the current high sensitivity assays are. When we looked at treatment, we found that just 1 in 3 patients with obstructive coronary artery disease were on medical therapy, and a similar proportion of those with LV systolic dysfunction, suggesting a possible treatment gap. And I would also like to highlight the work of a colleague, Dr. Kieran McCarthy, who works in Harvard and Boston, who has done a similar study. They applied CT coronary angiography, specifically looking for coronary plaque, and also applied CT-FFR in 50 patients with type 2 myocardial infarction, a similar age and distribution of sex to our population. They found that any stenosis was present in 92% of this population, with severe disease in 1 in 3, and 62% of patients had evidence of ischemia by FFRCT. So very comparable with the information that I've shown you from our study here in Scotland. So what current investigations do we have which can help discriminate the diagnosis? Well, here's a patient with inferior ST segment elevation, presenting with typical sounding cardiac chest pain. And for all the money in the world, you would assume that they have an occluded coronary artery, likely due to a plaque rupture or thrombosis. So this was a coronary embolism, and the patient had evidence of neural aortic thrombus in a couple of different places. They also had evidence of stroke. So the ECG cannot discriminate, and I think we're all comfortable with that. Can serum cardiac troponin concentrations help us differentiate? This is a lovely illustration from one of my PhD fellows showing that when you model the rate of change in cardiac troponin and the peak cardiac troponin concentration by classification, type 1 myocardial infarction in red, type 2 here in gold, you cannot distinguish the classifications by either rate of change or peak concentration. So we know that peak concentrations tend to be higher. Again, this is the Abbott high sensitivity cardiac troponin I assay. So patients with type 1 MI, they do tend to have a higher peak, but it's not sufficient to discriminate at a statistical level. Can coronary angiography differentiate subtype myocardial infarction? Well, in isolation, I would argue no, it cannot. Sometimes you can see very clear thrombus on coronary angiography, of course, and that can help. But really, the gold standard is optical coherence tomography, which I'm demonstrating here. This is a fly-through of the artery, distal to proximal, showing you where there has been intimal disruption. If I just pause here to highlight, just at 6 o'clock, we've got atherosclerotic plaque, which is confluent at this point, and just at 6 o'clock there is evidence of an intimal tear and a plaque rupture. And as I move more proximally, there begins to be evidence of thrombus in situ. So this is a plaque rupture and thrombosis, and here is some more thrombus overlying plaque at 3 o'clock. OCT is not practical to be used in all patients. It requires contrast, it requires invasive imaging, and often these patients have small troponin concentrations. However, in the area of uncertainty, it can be invaluable. Echocardiography, we know, will demonstrate regional motion abnormality, which is an integral component of the diagnosis of any myocardial infarction subtype, and I would argue that echo cannot differentiate subtypes. And similarly, as I've shown you, cardiac MRI and late gadolinium enhancement is a variety of different patterns of scar, which can be due to a multitude of different mechanisms. This was a patient that actually presented with supraventricular tachycardia and ischemic chest pain and marked widespread ECG ischemia with evidence of multi-territory late gadolinium enhancement in that context of supply-demand imbalance with fixed obstructive coronary artery disease. So interesting patterns, but not significant enough to distinguish. And I've shown you this example already from a coronary embolism. So what opportunities do we have in research to try and distinguish myocardial infarction subtypes? Well, this is work from a colleague and friend, Dr. Evangelos Solos, consultant cardiologist in Glasgow, applying a tracer, 18 sodium fluoride GP1, which is specific for platelet activation and thrombus. And in this case, what they demonstrated was that in a patient who presented with an occluded circumflex artery, there was high signal uptake within the area which has been treated with thrombus behind the stent. And also there was evidence of thrombus in the left atrial appendage using this 18F GP1 tracer. So this is a non-invasive way of identifying the origin of thrombus and the presence of thrombus. And perhaps this could be a way that we could distinguish myocardial infarction subtypes, but of course this is a research tool. We also know that there are differences in the prevalence of low attenuation plaque between patients with type 1 and type 2 myocardial infarction, and low attenuation plaque appears to be more prevalent in those with type 1 MI. So what can you do at the moment in terms of risk stratification and treatment for this patient population who are highly prevalent? Well, we know that outcomes are poor. We also know that in patients with type 2 myocardial infarction, which I'll show you on the right-hand panel here in gold, this is the event rate for non-cardiovascular death at 1 year. So these are patients who are experiencing death usually due to advanced malignancy or dementia or infection most commonly. And what I want you to appreciate is that the patients in gold have a much higher risk of experiencing a non-cardiovascular death at 1 year compared to a patient with a type 1 MI represented down here in red, or patients with no myocardial injury in green. It's very important when you look at the rates of future myocardial infarction or cardiovascular death. Despite this vast excess in non-cardiovascular death, there is still a significant risk that that patient will have a recurrent MI or a cardiovascular death. And you can do advanced statistical modeling to take account for this, which is called a competing risk. And for an individual patient, the risk of having a future myocardial infarction or cardiovascular death is comparable between these two groups when you account for the fact that lots of these patients have non-cardiovascular events. And I think that really is important when we come to risk stratifying this patient population. This is not all just due to age and comorbidity. There is underlying cardiovascular disease here which could be addressed. And we know that there's a consistent observation of an increase in non-cardiovascular death across all studies. So highlighted here in blue is the proportion of deaths due to a cardiovascular cause. And in some populations, as many as 90% of patients are having death due to non-cardiovascular disease. So who should we be treating and how should we be treating them? Well, to some extent, the prevalence of type 2 myocardial infarction and myocardial injury that you see in your clinical practice will be dictated by the amount of testing which is done in your institution. And previously, I've collaborated with a colleague and friend, Dr. Yader Sandoval from Minneapolis Heart Institute, and we've demonstrated that between the United Kingdom, where there is quite selected testing of patients who have either chest pain or ECG ischemia, versus some centers in the United States of America, where more unselected testing is more prevalent as part of a panel of biomarkers, the prevalence is significantly different. So you are more likely to identify the true iceberg under the water if you do unselected testing. And we need to think about those individual patient level risk factors. So the risk factors relating to the illness, oxygen concentrations, anemia, heart rate, blood pressure, things that we can address, whether there are underlying coronary mechanisms which might contribute to ischemia. So is there underlying coronary artery disease in that 50% of patients I illustrated that's previously unrecognized? Or are there underlying structural heart changes, such as left ventricular hypertrophy, aortic valve stenosis, for example? We have attempted to try and come up with a score or a risk stratification tool which takes into account some of these factors, called the T2 risk score, which came out in JACC about 18 months ago. And this is one illustration of the potential use of routine patient data to try and identify those patients at higher risk. And what we demonstrated was that if your T2 risk score was high, you had almost fourfold increased risk of having a cardiovascular event within 12 months follow-up. And this used simple clinically available covariates, including age, ischemia, diabetes, previous heart failure hospitalization, a history of ischemic heart disease, your renal function, as well as some illness parameters like anemia, tachycardia, and the troponin concentration. We also showed that performed better than the GRACE score, which is used in some institutions for risk stratification. Another important question is whether the mechanism of type 2 myocardial infarction influences prognosis. So, as I illustrated already, the most prevalent etiology for type 2 MI is tachyarrhythmia in over 50% of patients. The remainder of causes, hypoxemia is second commonest, followed by hypotension. And there are also patients who experience a multitude of different insults at the same time. And when we stratify outcomes by these mechanisms, those patients who have a coronary mechanism were very, very low in number in this group, and I don't think that's representative. But those with tachyarrhythmia, here in the teal green line, have a very similar future prognosis of all-cause death to those with type 1 MI. Comparatively, those patients with hypoxemia in blue are at extremely high risk of experiencing death within 1 year. And this slightly reflects their illness severity, which is illustrated here as in the first 30 days when there's an initial high event rate, followed by this continuous trend upwards, which likely relates to comorbidity and possibly frailty. So what about coronary artery disease? Well, this is some pilot data recently that we've been looking at, which is patient outcomes at 5 years. These are consecutive patients recruited across Scotland, elevation in cardiac troponin concentration, about 10,000 of them in whom we classified the diagnosis. And the message from this illustration is that those patients in yellow type 1 MI are at lower risk of having a future death or myocardial infarction to those patients with type 2 MI and underlying coronary artery disease. And my hypothesis is that this is due to the fact that as many as half of these patients are previously unrecognized, and there is a significant treatment gap, with rates of statin therapy in this population of less than 50% and rates of revascularization often in the region of 10%. So at present, how can we approach diagnosis, investigation, and treatment? Well, I think of acute myocardial injury and type 2 myocardial infarction as a spectrum. Currently, the distinguishing factor is not the troponin concentration, it's the preemia, which can either be a subjective symptom or it can be the interpretation of the 12-lead ECG. And essentially, the illness severity and the presence of underlying risk factors is going to dictate which area of the spectrum that your patient falls. If we think of an example of the coronary artery disease model, to the left-hand side of this figure, when I came up with this illustration, I was a bit younger, but a patient who had a tachycardia with SVT of 180 for over 90 minutes and normal coronary artery disease, I would expect them to tolerate that fairly well without evidence of myocardial ischemia. Conversely, a patient with severe obstructive underlying coronary disease may not tolerate atrial fibrillation with a rapid ventricular response very well, and their ischemic threshold will be significantly lower. And again, there's likely to be a spectrum and a relationship between the magnitude of this hemodynamic stress, the underlying coronary artery substrate, and the likelihood of supply and demand ischemia. And this is taken from our recent state of the art review published in the European Heart Journal in January, which I would encourage you to refer to if you've been interested in anything I've talked about so far. There's another clinical question, and that is really which gray zone patient should have an angiogram. Now, in some centres, there will be a very low threshold for invasive coronary angiography for any patient who has elevation in cardiac troponin concentration. And in that context, this slide is unlikely to be informative. If you are working in a centre where there is more selective use of invasive coronary angiography, some of the factors which I think would lead you towards doing an invasive angiogram rather than, for example, a CT, or even not investigating, would be a higher peak troponin concentration, if there was only limited oxygen supply-demand imbalance, if there were regional ECG changes, if there were persistent symptoms, or if the patient was younger with a greater number of life years at risk were you to miss an important underlying coronary lesion. Conversely, those who you might consider an upfront CT for, or perhaps not investigating, depending on your local practice, would be those with a smaller peak troponin in the context of a very critical illness, those who have widespread diffuse ECG changes rather than a regional ECG change, and those who only experience symptoms at the peak of their illness. So I want to now take you forward to present day and bring you some cutting edge results, which were just presented by myself this weekend, and that's the Target Type 2 randomized controlled trial. So we really want to deliver a randomized controlled trial in this population to provide evidence that identifying and treating coronary heart disease and left ventricular impairment is of benefit to patients. So we led a pilot randomized control trial here in Scotland across 2 sites. We recruited 60 patients with type 2 myocardial infarction, and we randomized them to standard care, which, to give you some context, in Scotland would be about 15% of patients having a coronary angiogram, about 40% of patients having an echocardiogram based on clinician review, versus a strategy whereby the patient is risk assessed for coronary artery disease and LV impairment, accompanied by investigation and targeted treatment. And we wanted to see, firstly, if it was feasible to recruit patients with type 2 MI and randomize them, and secondly, to see how many of our recommendations would be followed at 90 days to give us insight into whether the trial would be feasible at a broader level. So this is a very busy illustration, but really what I want to highlight is that we identified 403 patients with type 2 myocardial infarction. There were a number of exclusion criteria, the most common being advanced frailty, which was the majority of exclusions. That was essentially people who were dependent. We also excluded those patients who were unwell and unable to consent, those with a GFR of less than 30, those who were pregnant or breastfeeding, and those who were aged under 30. So we had 143 eligible patients from 400 with type 2 MI. We approached 120 and we successfully randomized 50% of them. So a significant investment to translate 400 patients to 60 patients. We had a recruitment rate across sites of 5 patients per month, which is roughly what we anticipated, which was encouraging. And just to highlight the column on the left, the patients that we managed to recruit were broadly representative of the population. So a median age of 71 years, which is higher than the previous cohort studies I showed you both from myself and the group in Harvard. A smaller proportion of women than we anticipated due to screening fewer women in the last 2 months of the trial. But I would highlight that in the months previous, we were at 55%, and this is a very, very small group. And the other important thing to note is that 1 in 4 patients had previous coronary artery disease. And I want to tell you really what we recommended. So in half of the patients in our intervention arm, we recommended coronary angiography, bearing in mind that another 20% or so that was already undertaken as standard care. So roughly 70% of our population had coronary imaging, 80% had an echocardiogram. We made more than one recommendation in about 40% of patients. And by the end of the study, we'd recommended statin therapy for about 80% and either antiplatelet or anticoagulant therapy in about 90 to 95%. Importantly, we demonstrated adherence to our recommendations was 91%, which is very encouraging. And just to show you again, very, very small numbers, this is just indicative to show that we can capture the data. But in our intervention arm, the columns to the right-hand side, we increased the prescription of statin therapy, we increased PTY12 in those that couldn't take an aspirin, we increased DOAC therapy, but really very modest changes from this trial intervention at this stage. So we've demonstrated that it was feasible to recruit and randomize type 2 MI, but it required a lot of infrastructure and effort to screen consecutive patients. The adherence to our recommendations appeared to be quite good. We also felt that there were barriers to participation in this trial, and we learned a lot from the patients and the clinicians that took part. So as I alluded to, we did a complex intervention with flexible use of investigations dependent on an individual patient risk assessment. And actually, in truth, the simplest thing to do when we know the prevalence of coronary disease is so high is to find those patients in whom there is equipoise between doing coronary imaging or not coronary imaging. And so that's not your patients with recurrent ischemia, ongoing significant ischemia, for example, or significant peak troponin concentration, perhaps. But find those patients in whom there is equipoise and then randomize them to coronary imaging at that time. I think we need to revise our exclusion criteria. So we've had agreement from our patient involvement group that actually, if you're critically unwell, you should be reapproached in recovery. And we're going to do frailty assessments at an earlier stage, so a pre-morbid frailty assessment. We know actually that there are really no patient resources that are dedicated for type 2 myocardial infarction. And even in a literature review last week, I undertook that it's all type 1 myocardial infarction that's been repurposed. There's nothing specific. And patients really struggle with this because certainly in the United Kingdom, the guidance for driving is that type 1 and type 2 myocardial infarction are treated the same. I've alluded to the fact that systematic screening is a very labor-intensive task, and this may not be a scalable model. So in conclusion, I hope that I've demonstrated to you that type 2 myocardial infarction is highly prevalent in clinical practice, responsible for as many as 50% of the troponin elevation that you'll see in consecutive patients, and it can be difficult to distinguish from a type 1 MI without undertaking investigation. Currently, we have no clinically available biomarkers that can distinguish these two subtypes. We know that imaging, when it's done systematically, identifies coronary artery disease, but what I cannot tell you is if every patient would benefit from coronary imaging and treatment, or whether it's only a select population, and I'm working very hard to try and answer that question. We know, however, that there is a large unrecognized burden of cardiac disease. And unfortunately for those who are not a cardiologist, perhaps emergency physicians, one of the most common questions I get asked is how we can improve consistency of advice in this area. And I think really without clinical trial evidence, that's going to be very difficult because there are lots of different opinions, all of whom are valid based on interpretation of a very small evidence base, mainly around observational cohort studies at present. And finally, I just want to thank everyone that's contributed to the studies that I presented today. And I would encourage you to read any of the references that I provided. If you're interested in looking at some of the cases which were in our original prospective cohort study, we do have an educational resource available via this QR code. And I'd be very happy to take any questions. So thank you very much for your attention.
Thank you very much, Dr. Chapman. That was an amazing talk in a quite complex topic. So for everyone, if you have any questions, please put them in the Q&A and we'll go through them. I'll start with a question about invasive testing with, I guess question would be, what's the role of microvascular testing and OCT? You touched base on it, but which patients should get it and which ones should not?
That's an excellent question. So microvascular testing is a research question at present. So again, a colleague and friend, Dr. Raphael at the Mayo Clinic, is doing some work in this space. I don't think it's published as yet. I know from colleagues in Denmark that as many as 1 in 3 patients have evidence of a raised index of microvascular resistance in the context of sepsis, which seems to normalize by 2 or 3 months. So it may be that microvascular disease is prevalent, but no one has looked at this systematically to my knowledge. In terms of routine use of OCT, I'm an interventional cardiologist. I like OCT. I think it often clarifies the diagnosis, but I have to be honest, it's not without risk. You're instrumenting the artery, you're injecting more contrast into an artery which may be already disrupted. So you have to weigh up the risks and benefits for each individual patient. And when you're looking at a slightly more elderly population who are comorbid, who often have chronic kidney disease, we can't routinely do 3-vessel OCT, that's for sure. But certainly in selected cases where you're uncertain if it's a type 1 or type 2, as long as you've not pre-dilated the lesion, I think OCT can give you really valuable information.
Do you use it for the patients when you suspect SCAD or not?
So I don't routinely use OCT in SCAD. However, there is evidence to show that OCT is safe in SCAD if you look at registry data, and I think some people would encourage you. I suppose my personal bias is that I think for the most part, a high definition IVUS will give me the answer without injecting contrast. My understanding is that the concern about injecting contrast at pressure down an artery with SCAD has slightly been debunked because the pressure from coronary blood flow is actually much higher. So you are unlikely to make it worse, but that's a personal opinion.
Thank you very much. That's a very important thing. So we have a question from Daniel Lorenzati. He says, thanks for the great overview. You left very little room for questions. You mentioned tachyarrhythmia as a common cause of type 2 MI. These patients often go to the cath lab and are found to have bystander CAD. Do you think revascularization could improve outcomes, or is it more like stable CAD?
That's a fantastic question. That is a trial I would love to do because from my hypothesis and my bias, I view these patients as failing a physiological stress test. So rather than putting your stable coronary artery disease patient on a treadmill and seeing regional ischemia, your patient has been stressed with tachyarrhythmia, and as a result, their fixed coronary artery disease may have reduced their ischemic threshold. So certainly to my mind, it's logical that revascularization would reduce that patient's ischemic threshold, or perhaps increase is the way to phrase that correctly. And that might reduce the likelihood that they have type 2 MI. For example, I have a patient on my patient and public involvement group here in Scotland who every time they develop atrial fibrillation with a rapid ventricular rate, they're experiencing recurrent symptoms. And what they want is an ablation, and they want PCI, which that's what they're waiting for. So it's a great question. It's a research question still for me. It's a case-by-case basis. If someone has a recurrent type 2 MI in that context, I think you have license to discuss it with the patient for sure.
I was going to say, I don't think Luigi Di Biase is here, or head of EP, but if he was here, he would probably say ablation. But you mentioned that too.
Absolutely.
So a question from Dr. Monrad, one of our cath attendings. So you cath a positive troponin patient. They have a coronary stenosis, but it has no hallmarks of unstable coronary disease. This is kind of similar to what we're talking about. Do you stent that predictably found stenosis in a patient with type 2 MI. I guess just to push it a little bit forward to you, do you think it's vulnerability testing in the plaque would change any of that? I mean, you already said that we need clinical trials, but would the vulnerability of the plaque or the characteristics help you in that decision there, or is just treating the underlying cause?
I think for me, it's treating the underlying cause. Now, if the patient has got symptoms of angina, it's very easy to fix the stenosis, and I think if the patient's a recurrent presentation, again, you might have more of a strong rationale. Clearly, the other major important group is those who have what we believe to be prognostic important coronary disease. So, if you identify left main disease or proximal LAD disease, I think you could certainly have a conversation with the patient. In terms of plaque phenotyping, again, fascinating question. Do these plaques share characteristics with non-culprit plaque, for example, in patients with multivessel disease and STEMI, where we know complete vascularization helps? Possibly, perhaps. Again, I'd love to look at that, and it's a research question for me. But these are all individual patient-level decisions.
Yeah, and they're very tough. I think I have a question about where the field is moving forward with biomarkers. There have been some kind of combination of biomarkers, novel biomarkers suggested that could make a better differentiation between type 1 and type 2. What are your thoughts about new biomarkers?
So there are different options here. I do have some slides on this, but essentially there are different things you can do. So you can apply panels of biomarkers where you use more than one test at once. And some of my colleagues in Germany have shown that when you use things like copeptin, procalcitonin, cardiac troponin I, atrial natriuretic peptide, when you take all of these together, you can improve the discrimination for type 1 versus type 2, and you can get an area under the curve up to about 0.85 from 0.6 with troponin alone. There are other biomarkers. So I have colleagues in Finland who are leading on a new long-form intact cardiac troponin assay, which I think is really interesting. So they've published already in circulation about this long-form assay. And essentially their hypothesis is that in order to release the intact cardiac troponin assay, you need to have had cardiomyocyte cell wall destruction rather than leak of cardiac troponin from the cytosol, which can occur in a fragmented state. Taking a step back, all of our current troponin assays in clinical practice can pick up fragments of troponin, which could be far away, and they don't show the entire length of the troponin molecule. So if you have an intact troponin, which you detect in the bloodstream, that's more indicative that you've had a type 1 myocardial infarction and proper evidence of cardiomyocyte necrosis, not a stress-related cytosolic leak of fragments. So that's their hypothesis, and they're testing it prospectively. If they can pull that off, that would be transformative because it would really help us without doing these invasive tests.
Yeah, thank you very much. Like you said before, here in the US, in multiple sites, we have a different approach. So people get tested with troponins when they show up to the ER. So we have a question from, I think, probably our fellows. Is there any way to differentiate between MI and acute myocardial injury or necrosis due to coronary blood flow? I think oftentimes we assume many of these are due to poor flow. However, metabolic dysarrangement such as altered cellular pH can also cause a troponin leak.
So it's a good question, but the short answer is no. So cardiac troponin is specific for myocardial injury, not infarction. And myocardial infarction is a clinical diagnosis based on symptoms and signs of ischemia or imaging evidence of infarction. So the long and short answer is no. And I approach every patient with acute myocardial injury as if they're a patient with acute kidney injury who's got a raised creatinine in the context of being unwell. And I think you need to start with your surgical sieve of thinking of all the potential differential diagnoses, one of which is plaque rupture myocardial infarction. But on the other extreme is someone who's got pristine coronary arteries who's under extreme physiological stress.
Thank you very much. If you have a couple more minutes, another question from Daniel Lorenzati. He talking about cardiac MRI. We do advanced imaging here. So this point was going to come up. He says, I agree with you that cardiac MRI cannot differentiate between type 1 and type 2. But don't you think that a cardiac MRI first approach, including edema imaging and selected STEMI cases, could help identify and treat the culprit lesion by assessing the affected territory? And I add to that, maybe identifying myocarditis potentially in this case.
Yes, I think so. I've certainly seen MRI first as a proposal for patients with Minoca, for example, which is slightly different to type 2 MRI that I've not discussed today, of course. But yes, I certainly think edema imaging, when it's interpretable and when you get the patient at the right time point in their journey can be really very helpful. Does it have the sensitivity for us to then direct coronary revascularization? I'm not sure. It might have enough sensitivity to lead you to triage that patient to further investigation, for example, coronary imaging with OCT, to really nail down the diagnosis. But again, I think it would be a really interesting research question to explore, because at the moment we've got no firm guidelines on what to do in these patients, and all of the points you've raised have been excellent.
Yeah, even to decide on cardiac MRI versus CCTA versus some nuclear, right now it's very dependent on the attending, right, on the expertise. So it's hard to create a standardized guideline on this. I think as a last question about antiplatelet therapy and treatment, you have multiple causes. So is there anything kind of a grouping of decision for dual antiplatelet therapy versus NOAC that any comments on that decision?
Yeah, so I think that's a difficult question. I'm sure there are patients with type 2MI who have featured in clinical trials of dual antiplatelet therapy, but certainly there's nothing been reported about that particular subset. We know these patients are older. We know they have comorbidity and chronic renal disease. Their bleeding may therefore be different. And for me, there's no role for dual antiplatelet therapy in patients where you're happy and comfortable it's been a type 2 MI. I think secondary prevention as a pragmatic decision in patients where you confirm coronary artery disease, as you would with a stable patient, is probably the way to go for the moment. And clearly, if you have an indication for a DOAC, so for example, atrial fibrillation or DVT-PE, then that would take precedence over a once daily aspirin. But DOACs for me, dual antiplatelet therapy for me, not at the moment. I don't think there's enough evidence to support that.
Yeah, thank you very much. I think just as a last one, we have from Ahmed, considering reclassification of patients with type 2 MI based on high sensitivity assay, do you think renal impairment or renal functions assessment can impact the diagnostic thresholds?
Well, we know that patients with renal disease typically have higher troponin concentrations, but the diagnostic thresholds at present are applied the same, irrespective of age and renal function. The one thing that we have noticed, based on our previous research, is that with some cardiac troponin assays, men and women seem to have different normal reference ranges. And that's very important, because when we used the Abbott high sensitivity troponin assay, when we lowered the threshold in women from 26 down to 16 nanograms per liter, we diagnosed a number of additional myocardial infarction events that would previously have been missed. So although there is some discrimination between different subtypes based on sex, presently we're not doing that based on age or renal function. It's just an awareness that that patient is more likely to have chronic myocardial injury, and that's where doing serial testing is really, really important to differentiate acute from chronic.
Thank you very much. This was outstanding, and we learned a lot. And I know you're busy, probably have a lot more PCIs to do. So we'll let you go. Thank you so much for your time.
Thank you for the invitation. Thanks again.
Bye-bye.